Assalamualaikum warahmatullahi wabarakatuh. Good afternoon and a very warm welcome to everyone. Thank you, Dr. Latha, for joining us today, and thank you everyone for joining today's CME webinar organized by Unit HIV, STI, and Hepatitis C, Jabatan Kesihatan Negeri Johor. My name is Dr. Nadia, and I'm honored to be your moderator for today's session. Today's CME is titled Syphilis, Rising RPR Titre, Distinguishing Reinfection from Serological Variation. This session also marks the first in a series of CME webinars that will be organized by Unit HIV of Jabatan Kesihatan Negeri Johor. We certainly look forward to many more meaningful and enriching academic sessions to come. As I'm sure everyone is aware, syphilis remains an important public health concern. An interpretation of serological results, particularly rising RPR titers, can sometimes be clinically challenging, especially in distinguishing between reinfection, treatment response, and normal serological variation. Hence, today's topic is both timely and highly relevant to our clinical practice. To guide us through this important topic, it is my great pleasure to introduce our speaker for today, Dr. Latha, anak perempuan R. Selvarajah, consultant dermatologist and head of dermatology services for the state of Johor. Dr. Latha graduated with an MBBS from the University of Malaya and obtained her MRCP from Ireland and later completed her advanced Master of Dermatology at the National University of Malaysia. She currently serves as the head of Department of Dermatology at Hospital Sultan Ismail, Johor Bahru, and is actively involved in clinical research, medical education, and the development of dermatology guidelines, both nationally and within the Asia-Pacific region. Dr. Latha is also a well-recognized speaker and panel expert, frequently invited to present at local and international dermatology conferences and scientific meetings. Throughout Dr. Latha's distinguished career, she has received numerous accolades, including multiple Excellence Service Awards, the American Academy of Dermatology Scholarship Award, and the Korean Society of Investigative Dermatology Fellowship Award. Dr. Latha has also contributed extensively to peer-reviewed medical publications and continues to play an active role in mentoring and training healthcare professionals. With Dr. Latha's extensive expertise and dedication to advancing dermatology care, we are truly honored to have her with us today. Please join me in welcoming Dr. Latha. Without further ado, I would like to invite Dr. Latha to begin today's session. Doctor, the floor is yours.
Thank you, Nadia, and thank you everybody for coming in. Nadia, am I clear?
Yes, you're clear.
Okay, all right. Okay, so I do see like up to like 300 plus already here. I think it's a very mixed crowd. Okay, saya akan campur-campur lah BM dengan English so that I can cater to almost all of you. Not so sure whether most of y'all are MOs here or because I saw got some pharmacists, got some macam paramedics semua tu. So this one is actually very important because syphilis, the first person that go and see usually, for all these STIs are usually at the primary care, be it at a GP ke ataupun at the, your clinic kesihatan. And then sometimes as paramedics, sometimes they don't want to tell the doctor, they tell you, then you sendiri boleh macam, this one you really have to check, your partner have to check. So then after checking, then bila datang semua this RPR, that is the one that you have a lot of problem lah. Nak treat, tak nak treat. Is this like significant enough or not? Do we have to repeat? Do we have to give retreat? So that's always the issue. So I'm going to share my slides very soon. Actually, I got some for voting actually in terms of I'm going to give case scenarios. But kalau saya cakap, it's not going to be I don't know whether you understand or not. So later when I am going to ask case scenario, maybe you're all type inside the chat. Kita ada chat box kan, Nadia?
Yes, we do, Doctor.
Okay. So maybe because later I share screen, I don't think I can see the chat box. Maybe I try to minimize screen and see because I'm not so familiar with this Google one. Usually I use Zoom. So anyway, I'll try my best to make sure that you all understand. Okay. So let me just share my slide first. Right. Okay. All right. Is it clear?
Yes,
clear, yeah? All right, okay.
Can you reshare your slide again, Petra?
You can't be seen, is it?
No, we can't.
Oh,
Just
okay.
it did for a split second, and then it's not we can't view it anymore.
Oh, okay, wait. Let me try again. I'm sharing right now.
Okay, you can see it.
Okay. All right. Slow down. Can? Is it now okay? Is it okay, Nadia? Can see? Can you see my slide? Can see my slide?
No, we cannot. We cannot see your slide. Can you reshare the slide again? We did see for a few seconds, but I think you probably pressed a button that caused the slides to be minimized.
Oh, okay.
Initially, see your slides.
When I'm going to this, it will come out like okay. So when I'm pressing my slideshow, that's when now you can see, right?
Yes, now we can see your slide.
But when I press my slideshow right now, can you see?
Okay, therefore what you have to do, I think, is you have to, when you press the share, you must share the window, not the whole screen.
Oh, it must be window, huh?
Right.
Okay, wait, let me see. Yeah, actually I did from window actually. So from window, what is this? I put there and then I am sharing right now. So you can see, right? So I'm sharing my window, but if I press my slideshow, I'm going to press it now.
Okay.
Can you see?
No, you cannot anymore.
Okay, maybe I will need Taufik's help to Encik Taufik's
Would you like us
share.
to share it from our side? Yeah. Okay, sure.
I think easier. But in this case, I'll just say next lah. Encik Taufik
Yeah.
boleh?
Yes.
Okay. All right. So we go to the next slide. Okay, this is my disclosure slide, right? So, okay, next slide. Okay, next slide. Okay, so syphilis, you all know, is it moving on its own or what? Can you go before? 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 Okay, syphilis, as you all, next slide. Okay, syphilis, as you all know, it's a very distinct, it's distinct, but then, you know, it can present in many ways, all right? Sometimes your clinical suspicion must be very high. Kalau you tengok this rash, a bit abnormal, okay, typical syphilis rash, later I will tell you all how you look like, but then, you know, it can present like anything. Sometimes I've got patient datang macam psoriasis macam tu, tapi when we screen the RPR, it's actually syphilis. And bila kita treat, actually all the plaques melted away, and this one usually kita tengok dalam HIV patient. Alright, so just remember whatever rash yang you tengok, you know, if you think that you're not so sure, always send a RPR. Okay, sometimes you akan surprised it suddenly become positive. Next slide. Okay, so mainly if you want to go for reference, right, for management of STIs and in particular syphilis, you use the CDC and also use our Malaysian guidelines, which was actually published in 2024. Next. Okay, so today I'm going to actually talk about how we're going to recognize syphilis, and then the most confusing part, how you're going to interpret. Ni RPR ni significant ke, tak significant ke? Okay, is this infection? Dah treat, is it infection lagi sekali ke, ataupun ini just the serological variation? That means dia up down sikit, tapi it's not really you know, a true infection or true reinfection. Because you got to remember, yang buat ni dekat lab technician. So when diorang macam put in patient serum, And then after they add in, for the test RPR, usually they will add in that non-specific antigen inside so that the antibody will bind towards it. Nanti dia akan tengok dia punya clumping, and from there dia akan measure berapa dilution yang dia boleh nampak clumping tu. Alright, so sometimes it's depend on the technician how familiar they are. So sometimes it can be higher value, sometimes lower value. That's why you have to interpret, sebab sometimes dia memang ialah variation saja. And then once you dah cakap, okay, this is syphilis, how to manage, and this is the follow-up part bila you buat all the tests, and then you're going to see whether you're going to like treat, retreat, is this reinfection? That is how you will follow up, and then the period of follow-up, and then most importantly, we'll have case scenarios after that. Okay, next. Okay, so syphilis is caused by Treponema pallidum. If you want to know the name, it's a spirochete lah. All right. Okay, and transmission. So you see here is either sexual transmission or blood transfusion, or else through percutaneous sharing of needles. So sini tak ada anything to do like syphilis coming from contaminated toilet seat semua tak. Very, very unlikely, because this spirochete cannot really survive outside the body. So when the patients like come in, of course dia rasa malu, so you have to understand them also when they say like, maybe it was a public toilet, all that. So slowly lepas you dapat macam bonding dengan your patient, then slowly you boleh ambil better history. Okay, next. So you see the incubation period, that means kan daripada masa you expose kepada kuman syphilis tu, and then the time you get the symptoms, right? For the primary syphilis, okay, syphilis tu you ada two ways. Satu kalau dia ada symptoms, that means dia boleh nampak ada rash ke, ada ulcer ke. Satu lagi dia tak ada symptom apa-apa, kita just check. Sometimes because of like this patient nak buat HD ke, this patient nak start some immunosuppressive treatment ke, ataupun this patient pregnant, so we just take, and then suddenly become positive but patient no symptom. That's what we call as latent syphilis. So syphilis, once you expose, usually the first symptoms will come about, kalau ada symptom, it come between 9 to 90 days. Alright, so that's what we call primary syphilis. That's why we said kalau dia patient ni kita dah confirm syphilis, so kita kena treat partner. Kalau partner dia was already have any sexual intercourse within 90 days, it's the incubation period, so usually we have to actually treat this patient. If it's more than 90 days, usually that patient. So if it's more than 90 days punya contact, that means this patient just need diagnosed as syphilis, tapi dia punya partner tu the partner tu, the last sexual contact was more than 90 days, so maybe the partner might not be infected. Okay, so what we do is we have to check the RPR and then decide whether partner is infected or not. Alright, so that's primary syphilis. Secondary syphilis yang selalunya yang kita nampak yang paling senang diagnose syphilis is when the rash come, especially over the palm and sole. Okay, tertiary syphilis sangat jarang kita nampak sebab nowadays you all treat very well. Okay, so the patient will, if tertiary syphilis, usually they have a lot of these infiltrated looking plaques. Okay, very seldom. I sendiri tak pernah nampak tertiary syphilis. Okay, and then sometimes they can have these neurological symptoms macam this general paralysis of the insane, tabes dorsalis, and dia akan ada a bit of like macam this foot drop, all that. That very, very seldom we see. Okay, and then the other entity yang I cakap tu latent syphilis, patient tak ada symptoms apa-apa tapi masa screening nampak positif. Okay, one thing about dulu kita cakap neurosyphilis was a tertiary syphilis, but actually now we know neurosyphilis can occur at any stage of the disease. They can come very early within that 9 to 90 days incubation period, or they can even come very late. So we must always look out for neurosyphilis after I'll tell you the symptoms of it. Next. So primary syphilis, usually the one that they present with is actually a painless ulcer. Alright, okay, kalau herpes sangat painful, this one is a painless ulcer. Sebab ulcer ni tak sakit, selalunya patient takkan datang jumpa doktor pun. Because ulcer dalam 3 atau 6 minggu, dia sendiri akan cure by itself. So this is the part always miss. Tapi kalau masa ulcer ni dia ada sexual intercourse ke, ataupun ada any contact, physical contact, the chances of the partner or the other person to get the syphilis is actually very, very high because the number of the treponema pallidum there is very, very high. And also remember in primary syphilis, if we check the RPR too early, maybe like we check 9 day, 10 day, kan dia boleh positif sampai 90 days. So sometimes we check early, we may see it's negative and then we think, maybe this one most likely tak ada syphilis. Tapi have to remember, kalau your suspicion is very high and maybe the negative is because it's too early, dia jadi macam false negative, you have to repeat the RPR after, if kalau you very high suspicion within 3 to 4 weeks, but you know, just make sure up to like 90 days, it can still be positive at that time. Next. Secondary syphilis. Ini yang kalau you nampak apa-apa rash dekat palm and sole, and especially kalau it is not itchy, you have to really suspect syphilis. Okay, and this secondary syphilis also, usually the treponema pallidum will be very high, and this is what we call sometimes whenever we do that RPR, right? Sometimes it might be negative. This is apa yang kita cakap yang pro-zone phenomenon. Later I will talk about it again, where the antibody is so high that dia tak boleh clump masa kita do the testing with the RPR. It's just macam you imagine kan, dalam satu bilik full of people, dia tak sempat nak shake hand dengan semua, so you tak dapat contact, so the antigen antibody cannot contact, and that is why it doesn't detect as like clumping, dia akan jadi macam false negative. So in that case, usually kita akan proceed to do TPPA ataupun kita akan minta the lab, please do more dilution so that they can actually get, when you dilute more, the antibody will be more diluted, then the results will become positive. So other than the rash, patients can present with a bit like this warty looking lesion where we call, bukan nama saya, but it's called condylomata Latha. Alright, and sometimes they can have alopecia patches. Okay, so that is when kalau ada suspicion, we also send the RPR. Okay, next. Okay, tertiary syphilis is very rare, memang jarang jumpa, and usually by tertiary syphilis, patients are no longer infective. But we don't want to reach them because we want to treat our patients early. Next. Okay, neurosyphilis. This is very important. This is especially important kalau kita dah treat RPR langsung tak nak turun fourfold. Okay, especially yang high titer, kita kena betul-betul suspect neurosyphilis. So when you want to suspect neurosyphilis, you have to ask symptoms like, you know, like a meningitis-like symptoms, a very chronic headache. Patients have, stroke-like symptoms. And then you also have to ask eye and ear involvement. Kalau dia ada a lot of vision blurring ataupun ear, they hear a lot of tinnitus, all this, tolong refer kepada ENT or eye because you need to assess whether there is actually an ocular syphilis or not, or any auditory involvement. Sebab kalau yang tu, that is a telltale sign, ini kemungkinan besar neurosyphilis, alright. And patient dia tak cukup dengan IM benzathine tu yang 3 kali, dia kena masuk ward untuk IV, right? Okay, so next slide. Latent syphilis is the one most of patients have. That means dia tak ada simptom langsung, tapi masa kita buat screening RPR atau VDRL, then kita nampak dia positif. So very important to ascertain ini early latent ke late latent syphilis, sebab bilangan injection yang kita nak bagi masa rawatan tu berlainan untuk early dengan late latent syphilis. Okay, next. Okay, for early latent syphilis, macam kita tahu, is this, are we going to label this early latent syphilis within 1 year ke, or is it late latent, it's more than 1 year? So kalau kita ada titer dengan titer patient yang RPR dah pernah buat sebelum tu, so dalam tahun yang sama the RPR titer went up more than 4 times, then we know that this is actually an early latent syphilis. Atau kalau patients ada symptoms of early syphilis, yang tadi saya cakap rashes ke, yang ulcer tu ke, then we know this is early syphilis. Okay, and then dia ada contact within this last 1 year dengan patient yang ada syphilis tu, so we will label this patient as early latent. But sometimes, you know, you tanya semua pun tak. Alright, and then you really don't know. So if you don't know, kita akan label the patient as late latent syphilis. So if you're not sure if it's early ke, this is late latent syphilis, we will automatically presume it's late latent syphilis because injection for late latent syphilis must be 3 benzathine penicillin injection. Macam kita torture patient tu lah, kena cucuk 3 kali dan sangat sakit lah. Okay, we have exceed our patient suffering. Next. Okay, so diagnosis is actually to most of the time kita akan buat RPR atau VDRL. And then kalau itu positif, then kita akan buat yang treponemal specific punya test, which is actually the TPPA ataupun TPHA. Next. Okay, so the non-specific, non-treponemal one, the first one that we do, this is the one, the VDRL atau RPR. So, kalau you tengok, this one is actually measuring the antibody. Dia bukan against the treponema, dia antibody against this cardiolipin lecithin cholesterol antigen. What this is actually something that kalau seseorang tu ada syphilis, and when you are treating the syphilis, the tissue damage will release all these antibodies. Okay, so that is the one that we are actually detecting. Alright, so that is why it's not directly detecting this syphilis. So once RPR positive, kita kena confirm dengan another test, which is the treponemal test. Alright, okay, because this RPR test can be false positive. Next. Okay, so kalau RPR, VDRL dah positif, then kita kena confirm dengan yang kita selalu guna sini, TPPA ataupun TPHA. Dan ini yang memang specifically measure untuk treponemal pallidum. Dia cakap, why not we just straight away do the treponemal test? Why you need to do yang bukan spesifik punya? Because this treponemal test, once patient dah ada syphilis, dia forever positif. Walaupun you dah treat, it's forever positif. So kita perlu the RPR. So RPR dia RPR yang bagi yang value. RPR atau VDRL. Yang 1 in 2, 1 in 4, 1 in 64 semua tu, itu daripada RPR. And based on that RPR atau VDRL is the one that we're going to see whether our treatment is working or not. Test ini yang treponemal, yang TPPA dengan TPHA tu hanya untuk confirm, tapi tak boleh guna untuk treatment response monitoring. Okay, alright. And also when you're having this test positive, saya cakap forever be positive, ini sekarang punya infection ke old infection, kita takkan tahu. Ini hanya untuk confirm this is syphilis. Next. Okay, so this is the screening. So first you akan buat VDRL atau RPR. Okay, I know in your clinic settings you all buat RTK. So RTK is the rapid test kit. It's also test using a treponemal test. But if your rapid is positive, you all know you all akan hantar untuk RPR and also your TPPA, right? Okay, so we skip straight to this RPR and TPPA. Kalau RPR is actually reactive, kalau you tengok on the left hand side, okay, dia RPR reactive, okay, then you kena buat yang TPPA atau TPHA. Kalau dia pun positif, so ini memang syphilis. Tapi kalau RPR positif tapi TPPA itu negatif, and then kita cakap ini false positive. That means dia most likely bukan syphilis. And later I'll tell you what are the reasons for it. Tapi kalau RPR tu dah jadi negatif, okay, selalunya kita tak proceed untuk TPPA. Tapi remember I told you that prozone effect. That means dia punya syphilis early stage yang terlalu banyak dia punya antibody dalam badan sampai that cross-link tak boleh berlaku. So because of that, sometimes we have to call the lab, our index of suspicion high, to call the lab, tell them, can you do more dilution? Ataupun hantar juga yang TPPA. So kadang-kadang kita pun banyak argue dengan lab. Like why you need to send down a negative, then said no, it's really needed. Okay, next. So when you have your RPR positive, TPPA positive, okay, we know that it is syphilis, tapi ada this rare ada spirochete yang boleh juga bagi positivity macam yours atau pinta, tapi usually that one in Indonesia, Philippines, the infections are usually there. Tapi kalau VDRL positif, TPHA tu negatif, then kita cakap ini unlikely to be syphilis. This is actually the false positive. Okay, so tapi kalau RPR negative, tapi we went on and did the TPPA, okay, so we said that this is actually syphilis, but then mungkin treated syphilis because kan saya cakap TPPA will be positive for life. Kalau dua-dua ni negatif, alright, so unlikely syphilis unless patient ni, the incubation period datang terlalu awal, so maybe the early part very negative. Kalau index of suspicion high, patient memang ada high risk behavior, tolong repeat after about 4 weeks. Okay, it can be up to like 9 months, up to like 90 days or so, 3 months, yeah. Next. Okay, so tadi saya cakapkan RPR positif tapi TPPA negatif. Ada beberapa condition yang boleh jadi tu. That's why RPR positif you kena confirm dengan TPHA positif. So this is the one like any viral infection, bacterial infection, pregnancy. Okay, so your pregnant ladies, if RTK positive, all that, you must actually confirm dengan, you have to do a proper TPPA to make sure this is not a false positive. Alright, elderly patient and then especially patient yang ada connective tissue disease semua tu dia boleh jadi false positive. So kena ingat tu ya. Okay, next one. Okay, so this is like a bit of summary. Sometimes the one that I'm stressing in the beginning, the first screening can be negative in early syphilis. If you're very, very suspicious, tolong repeat RPR within 3 to 4 weeks, okay? And usually most of our patients yang memang dah treatment, dah adequate, memang treatment yang betul-betul dah bagi dia semua injection dah complete within the time. If they become negative, that is good. Tapi most of the time they tak become negative. They stay at this low positive, 1 in 1, 1 in 2, 1 in 4, 1 in 8. Dia tak naik turun, sikit je kalau dia naik turun pun usually about 2-fold saja. So this is what we call as a serofast. And then the last one is that ozone yang I cakap, sometimes the antibody can be too high. That means it's so high, especially in the primary and secondary syphilis, that cross-link doesn't happen. So it become false negative. So kalau kita suspicious, you kena minta untuk extra dilution or you send for your TPHA. And this condition usually you see kalau patient ada advanced HIV, patients who are pregnant, sometimes this can also happen, okay, and especially in secondary syphilis, right? Next. Okay, treatment, I think like kalau doktor semua tu, you all know, primary, secondary, early, latent, kita hanya perlu 1 single dose and it is IM benzathine penicillin. Nothing is superior to the benzathine penicillin. Bagi doxy, bagi azithro, you always have to remember that there is high risk of treatment failure. Tapi kalau you bagi benzathine penicillin IM, it's very, very, very good because the rate of it to actually kill off the Treponema pallidum to sangat, it's very, very good. Okay, and for late latent syphilis is 3 injections. Okay, remember setiap injection tu ada gap seminggu. Okay, so kalau patient datang lambat, kita hanya kalau macam patient yang tak pregnant, kita allow sampai maximum 14 hari. That means dalam 7 days, day 7 dia kena datang untuk injection tapi dia tak datang. Kalau dah day 14 and above, you kena repeat balik. That means start daripada dose 1, 2, 3. Tak boleh sambung kalau dia dah gap 14 hari daripada the first dose. Tapi kalau pregnant lain, kalau pregnant dia punya gap tu lebih daripada 9 hari. Masuk hari ke-10, you kena start balik treatment daripada first injection and second injection, third injection. Okay, all right. This is something very, very strict so that we know that the syphilis is adequately treated. Okay, next. Okay, other than treating, okay, bukan saja your job, saya dah treat, bye-bye, thank you, saya dah habis kerja saya, tak, okay. You kena notify, jangan lupa notify, and then also you have to check for other concurrent STIs. Usually automatically kita akan buat Hep B, Hep C, dengan HIV screening for our patients, okay, and follow up, okay, for primary, secondary and early latent syphilis, the RPR kita repeat at 6 and 12 months. For late latent, 6, 12, 24 months. Kalau patient ada HIV, alright, and then especially HIV dengan CD4 count still low, you have to monitor more frequent. Sometimes very high titer, maybe we might repeat after 1 month. Usually for HIV, we do 3, 6, 9, 12, 18, then 24. Alright, pregnancy, I think KK you all are very good. Every month you all kena buat. Okay, neurosyphilis, especially kalau RPR titer kita tak turun, this is something we must think about. Tadi saya dah cakap dengan symptoms of neurosyphilis. So you need to actually send to our medical team, okay, and then medical team have to help us do the LP for the patient. Alright, never forget to check the partner. Alright, every time you fikir, Freddy, kenapa dia masih lagi ni? We did not treat the partner. So please trace the partner. Kalau the partner ada apa-apa contact within 90 days, very likely that partner is infected. Bagi aja treatment. Kalau more than 90 days, you boleh tunggu dulu. That means you can check first lah the RPR positive ke tak. Kalau you think the fella is not going to come back to you, you just treat the patient before. Just give that 1 dose at least, okay, of the benzathine penicillin. Next. Okay, so dah confirm, dah treat, dah confirm ini bukan false positive semua, dah treat. Okay, so lepas treatment, masa follow up tu, this is the where the problem starts. RPR. You have to ask yourself these 3 questions when they come back with your repeat RPR. Ada tak titer tu dah turun? And kalau dia dah turun pun, dia ada tak dia turun secukupnya dalam masa yang diberikan. Okay, kalau untuk early syphilis, kita boleh bagi masa sampai 12 bulan. That means we can monitor. Remember I told you earlier, RPR at 6 months and at 12 months, so you can give up to 12 months to wait for it to come down. The significant reduction must be 4-fold, but there are some exceptions later. I will tell you about it. Okay, if for late latent syphilis, you can even like wait longer, up to 24 months, because sometimes the titer takes very long to come down. HIV patients also sometimes the titer take very long to come down, so sometimes we have to keep on monitoring. As long as the titer tak naik 4-fold, it must come down, but it must be try to see whether it still can get a 4-fold decline. But sometimes we can't. I will tell you what are the conditions for that. Okay, so did the titer fall appropriately? Okay, one of the most important thing bila kita test RPR dengan TPPA untuk RPR untuk patient kita kan, if as far as possible use the same test. Kalau you guna RPR, you guna RPR. Kalau you're using VDRL, you guna VDRL untuk compare. Because sometimes dia ada sedikit difference between these two. And ideally same lab, tapi ini memang susah lah. Ke patient ke KK lah, ke klinik derm lah, ke GP lah. So it's quite difficult. But at least use the same test. Kalau dia guna RPR, guna RPR. Kalau guna VDRL, guna VDRL. And remember, setiap the changes in this RPR, right? It's not necessary dia naik sikit saja, oh dah kena retreat, patient dah reinfected. No, saya tak percaya apa dia cakap. You have to determine whether this is just a variation that is our talk about today, or is this patient kena reinfected ke, ataupun this is actually a treatment. Reinfected, treatment failure, not much of like changes, will still retreat the patient. It's only that whether you want to retreat penicillin or you want to try other agents, okay? So simple rule now that you have to remember so that you won't be so confused is that if kita dah dapat more than 4-fold decline, you all know what is 4-fold decline kan? Katalah daripada 1 in 60, dia turun jadi 1 in 4. That means it is 4 times reduction. Okay, that is 2-fold. That means 4 times reduction. Kita dah cakap what we call as a 4-fold lah, 4 times reduction. We say that this is adequate. Tapi kalau dia 4 times rise, that means in 1 in 8, dia tiba-tiba jadi 1 in 32. This is actually a 4-fold rise. Definitely this is either reinfection, previous treatment failure, mesti treat balik. Okay, of course you look for other things like neurosyphilis ke, patient ni partner dia treated ke tak. Ataupun the other thing sometimes you overlook is that previously orang yang treat sebelum ni, dia betul-betul ke bagi benzathine penicillin, mungkin silap-silap dia bagi ubat lain. So that is something you have to think about. So tapi kalau dia bukan 4-fold, ini yang kita cakap, tak ada 4-fold rise, tak ada 4-fold dia jatuh tak sampai 4-fold. This is where this what we say as the variation, this is where we have to observe. So this is, if you can remember this rule, it will be easier for you to interpret your RPR after this. Next. 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 Okay. So tadi cakap, did it come down? Okay. And bila dia come down, did it come down in the expected time? Okay, kalau untuk early syphilis, yang primary syphilis, secondary syphilis, dengan early latent tu, it must come down by 12 months. 12 months you punya maximum. Dia mesti kena 4-fold drop. Okay, then ini we say this is a adequate treatment. Okay, if not, then there are some scenarios to say that, you know, why is it like they don't have to retreat, all that, I will cerita after this. For the late latent syphilis, okay, we give up to 24 months. All right, as long as you see the titer is coming down, the titer goes up 4-fold already, that one you must treat. But if the titer up a bit 2-fold, down a bit 2-fold, that means one dimension, down a bit 2-fold, that is where this is what we call as the serological variation. Okay, next. So in pregnancy, what I want to say is that, you know, for early syphilis, I told you 6-12 months, you kena buat RPR. But in pregnancy, it's monthly. And you need to try to get that fourfold drop. But most of the time, actually quite difficult. And someone we know pregnancy is only that 9 months and the patient pregnant. Okay, so but then it's not going to be special. Oh, in pregnancy dalam 1 month kita definitely akan tengok dia turun. Tak, okay. But as long as we see there is no fourfold rise, we are safe. If you see fourfold rise in pregnancy, this month you check, next month already got fourfold rise, your threshold to treat is very low. You treat such a pregnant lady, okay? All right, if you don't want to wait for the repeat, you treat such a, because the time that we have is very short, and we are very, very particular that, you know, there is no transmission maternal to child transmission of syphilis, okay? So always remember that. And if any syphilis, you all know, if it's treated like less than 4 weeks of delivery, that means it's not adequate treatment. The child, the baby must be admitted for presumed syphilis. Next. Okay, HIV group, saya dah cakap, like, you know, the later we do at 6, 12, 24. Yang HIV group ni, we do a little bit more often because we are a bit like, you know, sometimes it doesn't come down very well. So we really have to think of whether this is actually neurosyphilis or not. Okay, and usually the titers also will be very high. So kita kena consider LP kalau dia ada that neurological symptoms, headaches, vision blurring ataupun any auditory symptoms, ini kena refer optal ataupun ENT untuk assess ini ada whether there's any ocular auditory syphilis or not. Okay, and also sometimes this HIV patient kita tak dapat dia punya fourfold decline ataupun dia memang selalu nampak dia punya rise to fourfold rise. Okay, and without dia cakap dia tak ada exposure langsung, tapi the RPR went out fourfold despite your treatment. So you really have to think whether this is neurosyphilis or not. Then we have to send them for lumbar puncture. Okay, next. Okay, so what are the things that we think that this can be treatment failure? Kalau patient dia memang ada sign and symptom of syphilis, yang tadi cakap chancre ke, the rash ke, lymph nodes ke. Okay, so this one, we say they still have the signs and symptoms. There is a fourfold rise, definitely there is treatment failure. When you see a fourfold rise, right, you treat the patient, okay? And then if you ada bagi cukup masa, 12 months the early syphilis, 24 months the late latent syphilis, tak dapat that fourfold decline, okay, especially for the high titer one, you have to think there is either treatment failure atau reinfection. So you have to retreat this patient. Next. So bila this treatment failure reinfection comes in, right, that means you tak dapat that fourfold reduction, okay, especially for the high titer, you kena tanya, ada tak patient ada signs and symptoms lagi sekali ke ataupun re-exposure, that means dia ada hubungan dengan patient lain yang ada syphilis. Ada tak you treat the partner already? And the previous treatment betul-betul tak bagi iron benzathine penicillin, or was it something else? And then you have to screen, re-screen, is there concurrent HIV or other STIs? That's why the treatment is not working. And always ask for symptoms of neurosyphilis. These 5 things you got to ask when patient tak dapat that fourfold decline. All right. But remember, sometimes we have later I will give you all the case scenarios, you know, where it start off is 1 in 8, tapi dia persistent lah 1 in 8, 1 in 4, 1 in 8, dah sampai, this is late latent, dah sampai 24 months macam tu aja. Dia tak naik more than fourfold, dia tak naik fourfold, dia pun tak decline fourfold. So this is where we say it's a zero fast. That means dia memang ada this low RPR positive, and usually it does not signify anything. This is the part yang most of us like, you know, even if you see the CDC guideline, what to do with this patient, most is like, there's no like known benefit to actually retreat this patient, especially kalau dia tak ada re-exposure. If your suspicion is high of neurosyphilis, you can actually do a LP. But if you think patient memang betul-betul no re-exposure, we can just follow up every year to see the titer, right? Next. Okay, so this is the one that I was telling you all about the zero fast. Selalunya dia ada this low baseline, dia tak naik fourfold or higher. So that means different dilution ni only one dilution. Kalau dia 1-2, dia naik paling banyak pun 1-4. Kalau dia 1-4, dia naik paling banyak pun 1-8. But from 1-2, it goes to 1-8. This is already fourfold, you must treat. Always remember this fourfold thing. Your main thing is like whether it goes up fourfold or not. If it goes up fourfold, that means 1 in 2, the 4 times 2, 8. So 1 in 2 goes to 1 in 8, you have to treat already. Of course, you always check for symptoms of neurosyphilis. Okay, so always remember about this zero fast. This is the one that we call is a variation because of the lack dilution and everything. So sometimes you have this variation, but it cannot be fourfold. Like it's went up one dilution, yes, we can accept. All right, next. Okay, so this one is a bit of RPR interpretation. Next. Okay, if a patient from 1 in 64 come down to 1 in 16 at 6 months, do you think this is an adequate response? Maybe we can see in the chat box. Do you all think this is a adequate response? Okay, so most people say this is okay, I can see some. Okay, mostly say it's an adequate response, which is true. Next. Yes, this is a good response because we get a fourfold reduction. Okay, next. Okay, 1 in 32 come down to 1 in 16. This is a patient with late latent syphilis, right? So do you think this is adequate response? Okay, I see one thumbs down, thumbs down. Okay, okay, you're pandai already lah, don't need to stop already, okay? So, what you're going to do? This is late latent syphilis, 1 in 16 in 12 months. So what you're going to do? You all nak what it is, just leave bye-bye to the patient? Correct. Okay, somebody, Dr. Mary, yeah, you answered. Late latent, you have the longest time you can give is 24 months. Next. Okay, so acceptable, we need to follow up to 24 months. Bila sampai at 24 months, if it's like this, 1 in 16, what you going to do? Belum dapat your fourfold reduction. What would you do? Any takers? So kan kita, I said that, okay, there is the zero fast, 1418 or zero fast, but this is 132. And then after that, kita dah tunggu sampai 24 months, it's still 1 in 16. Tak turun fourfold yang kita expect. What to do? Okay, very good. Ask yourself that 5 questions that I told you all. Okay, number 1, signs and symptoms of re-exposure. Is the partner treated or not? Okay. Was the previous treatment given correctly or not? Was it benzathine, penicillin, or some other treatment? Okay. And then, is there any symptoms of neurosyphilis or not? Okay. So these are the things you need to ask your patients. All right. And then after you can determine if, let's just say all these are negative, tak ada reinfection, HIV pun tak ada, okay, you already check and then recheck HIV is negative, partner all treated, adequate response previously, right? And then you have to ask about the symptoms of neurosyphilis as well. Don't forget, is it any headache ke, blurring of vision ke? So if any of these, then maybe because there can be a component of neurosyphilis, that's why they tak respond pada IM benzathine penicillin, it needs a IV. So before you give IV, you kena buat LP untuk patient tu. But sometimes all of these are negative, right? No symptoms of neurosyphilis. Sometimes we will retreat because kita tak dapat its fourfold decline, and then we continue to monitor and see. Alright, this is where it comes, where it continues to stay at 1 in 16. Most likely this is the zero fast for the patient. Boleh? Okay? Alright, if you have if you think you don't agree, just let me know. Tapi this is what is suggested by CDC. Next. Okay, 1 in 28 turun kepada 1 in 64. Adequate tak at 12 months? 64, and then after that is actually only one dilution, right? It's a two-fold only. 64 times 2, betul lah, 1 to 8 lah. So two-fold only. Adequate tak? Okay, ramai yang dah cakap tak adequate because, but this is because this is early syphilis. Okay, 1 in 28, 1 in 1 to 8, very unlikely to be late return. Okay, this is early syphilis. So early syphilis by 12 months, you dah macam kena decide nak buat apa. So next. Okay, so we need to, again, that 5 things I told you all about us, about signs and symptoms, any re-exposure, partner treated or not, previous treatment, all was it a correct treatment or not, ada concurrent HIV or not, any symptoms of these neurological symptoms. These 5 things kalau you tanya, semua tak ada, okay, but this one didn't come down adequately fourfold, you have to retreat the patient. Okay, then you continue the monitoring again for the patient. Okay, right? Next. So saya bagi sedikit case scenario and then I'll be done already, okay? So 28-year-old man, HIV negative, treated for early syphilis 1 year ago. RPR dia from 1 in 32 jadi 1 in 8, that 1 year ago. Lepas tu tahun ni, lepas setahun dia datang balik, RPR 1 in 16. So kalau tanya tak ada re-exposure, no symptoms. So at this point, will you retreat tak? Thumbs up mean retreat there. 1 in 8, it went up to 1 in 16 only, you know. Okay, this is like two-fold only. Okay, 1 dilution, two-fold. Okay, ada yang cakap no. Okay, next slide. Okay, actually from 1 in 8, initially 1 in 32, then it come down 1 in 8. So now you have to base on that 1 in 8 already. And then after 1 year is 1 in 16. That means it's two-fold. All right. So this is what we say it can be a serological variation, but still remember because the titer is going up rather than static. So it may be a telltale sign this is an early reinfection. It start with this two-fold dilution first. Maybe it's going to go up soon. So best is to repeat the RPR in about 2 to 4 weeks time. And this is the time kalau that 1 in 16 naik lagi kepada 1 in 32, okay, so because after treatment dah 1 in 8, so sekarang jadi balik 1 in 32 means that this is actually a reinfection. You have to retreat the patient if they keep on going up. Kalau dia static, you can still monitor. Alright, but again, please check again about any concurrent HIV and then also any symptoms of this neurosyphilis, because this is the one that usually causes our RPR not to come down adequately. Okay, next case. Okay, 40 years old, HIV negative, treated as early syphilis 6 months ago. Baseline 1 to 8. At 6 months, repeated 1 in 64. At 12 months, 1 in 64. Tanya dia betul-betul cakap no re-exposure, no symptoms, okay, no neurological symptoms, okay. Will you retreat this patient? Because there are 12 months, early syphilis. This is your cut-off point then. Okay, if you want to retreat, why you say you want to retreat? Why do you think this person should be retreated? Because there is no fourfold decline in this high titer. Next slide. Next slide. Okay. Previous slide. Before this, okay, because from 1 in 1 to 8 to 1 in 64, early syphilis at 12 months, still you don't get your fourfold decline. Next slide. So you need to retreat, but before you retreat, please ask that same 5 questions I was telling you all again. Any symptoms, ataupun re-exposure, partner dah treat tak, previously the treatment, was it like a proper treatment given, any concurrent HIV and any neurosyphilis symptoms. Okay, if all these things tak ada, but then no fourfold decline in this high titer, retreat the patient. Okay, retreat and then monitor some more. If after monitoring, okay, it's still static like that, CDC said that there is no added benefit that, further retreatment is going to help, okay, because about studies show, right, 10 to 20% of patients, right, somehow have this sort of like zero fast at a higher titer. As long as it doesn't go up another fourfold, patient is totally asymptomatic, okay, we can monitor every year. Okay, this is according to CDC. Next. Okay, 30-year-old lady, HIV negative, late latent. Dia 1 in 8. Lepas tu naik to 1 in 16. And then at 12 months, 1 in 8 back again. So no re-exposure, no symptoms. Will you treat? So thumbs down means you won't treat, right? Next slide. Okay, because this is a typical lab variation, 1.8, 1.16 comes out 1.8. So kalau dia punya dilution just times 2 saja kan, is usually a variation. Okay, always remember about your fourfold. You want to talk about treatment failure, it must be a fourfold rise. You want to talk about inadequate decline, it must inadequate response, if you tak capai your fourfold decline. Okay, and then when you tak capai your fourfold decline, you have to start asking all that 5 questions that I was telling you all about. But anyway, just now we stopped at 12 months only, right? So you can still continue to monitor this patient up to 24 months to really say that, this is actually inadequate response. Okay, you want to try to find that fourfold decline to say that this is actually an adequate response. Next one, I think this will be my last case already. Okay, so this is a pregnant lady, baseline RPR 1 in 2, treated as late latent syphilis, bagi benzathine penicillin, semua bagus. Okay, benzathine penicillin weekly 3 weeks, tak ada miss, tak ada more than 9 days. Okay, RPR 1 in 2, and then you repeat after 1 month, 1 in 4. You repeat after 1 month, 1 in 8. Low titers. No re-exposure, no symptoms, partner pun you dah macam betul-betul treat. Would you retreat? Okay, very good. A lot of say yes. Okay, next slide. Okay, any fourfold increase, just retreat. Especially walaupun ini low titer, sometimes if the non-pregnant you nak tunggu sedikit lagi, you can, because you're thinking whether it's like, variation. But rule of thumb, kalau fourfold increase saja, you must treat. Okay, and especially in pregnancy, you tak ada masa sangat. If they are going to deliver very soon, you tak retreat, habislah, you pergilah untuk yang kebangsaan punya meeting, ya. Okay, alright, so it's a very low threshold to treat pregnancy because you really don't want the baby to get congenital syphilis. Next, I think this is my last slide. Okay, in conclusion, right, always compare. Whenever you're treating, you compare dengan baseline. Baseline you treated, and then after what was the subsequent one at the 6 months, and then from there that subsequent one, the third reading akan based on your second reading, and then if at any time you ada fourfold rise, you have to assume this is already a reinfection or treatment failure. You have to treat. Do not react to a twofold change saja. That means in 1 in 2 you naik 1 in 4 saja. Please don't. You need to repeat and you need to see the trending. How is it? Okay, and then always remember asking about like any re-exposure, reinfection, partner treated, adequate treatment, concurrent HIV and neurosyphilis symptoms. Okay, in pregnant, kalau you betul-betul tak sure and it's very a lot of variation, you can consult definitely, and if the index of suspicion is very high, you treat. Okay, remember in syphilis, it's not about like you want to treat, you nak tengok RPR negative. Most of the time kita tak dapat. They are usually 1 in 1, 1 in 4, like that. What we want is that fourfold decline within that expected time. For early syphilis, you kena dapat that fourfold decline by 12 months. For the late latent syphilis, you need that fourfold decline by 24 months. If you don't get it, okay, alright, then you have to ask yourself that 5 questions. At any time, there are the fourfold rise, you must treat the patient again. Alright, so next slide, that is my thank you slide already. Okay, so I do hope you're not like this cat that you're smiling politely right now. I just hope that your afternoon spent here is really, really very beneficial. You've got some additional benefit listening at this, and you feel more confident in interpreting your RPR, and also, telling that is this a variation, is this something proper or not. So it's very, very important for you because you're out there in the primary care. Thank you so much, and I pass over back to Nabila. Yeah.
Thank you so much, Dr. Latha, for that very informative and practical presentation. We will be taking several questions from the floor. There's already person who are already raising their hand, and Dr. Iliana Basmuma. We're taking the question from you first. Dr. Iliana, are you there? All right. If Dr. Iliana is not there, then participant Yi Sin Lee, are you there? Do you want to ask any question? You're raising your hand.
Yeah, I would like to ask, Doctor, I would like to get clarification from when to proceed to TPPA, because at KK we use test kit for the reverse algorithm, and the reverse algorithm mentioned that to proceed to TPPA only if RPR negative. But just now during the session in the discussion, it's mentioned that if RPR positive, only we proceed to TPPA. Thank you, Doctor.
Okay, you are asking about reverse algorithm. That means you are already testing with treponemal test first. Just now when I was explaining, I was telling you about starting off with non-treponemal test. That means now the patient come in, suspected syphilis or whatever STI, you take the RPR. So your first test is the RPR. And if this RPR positive, you must confirm with TPPA or TPHA, because RPR can be false positive. Remember that. But in your KK, right, you all are doing RTK. This rapid test kit is actually a treponemal test, but it's still a rapid test. It's not the best, but then it is very fast result you get. So this is something like a reverse. So if your RTK is actually negative, right? And then if your RTK is negative, usually you don't do anything, right? But if your RTK is positive, and then you will proceed dengan taking your RPR, right? And then your RPR becomes, just now you're saying the RPR is negative, okay? So now there is a discrepancy. The specific one, treponema, is positive, but your non-specific one is negative. So you have to repeat with another treponema test. That means you have to do a TPPA or a TPHA to see whether it is negative, and you have to do like a different test. I think the RTK is TPP, the RTK is the chemical immunoassay, right? So you have to use another treponemal test. So that means you have to go for your TPPA ataupun TPHA. And then if this TPPA or TPHA is positive, and then this is likely to be syphilis. But if it's negative, then very unlikely this is syphilis. Okay. The reverse algorithm is actually quite confusing. To me also, it's quite confusing. I'd rather stick to the usual one. That means if you're doing RTK, it's positive. So you confirm straight with when your RPR, okay, or your RPR or VDRL. If that is positive, you need the confirmatory TPPA ataupun TPHA. It's very straightforward that way. Okay.
Dr. Latha, there's another question in the chat box from Lynn. It's a case scenario with 3 questions in it. So the question starts with, it is common for both couple being treated at the same time, but husband responded and titer remain at 1 to 2. But wife have titers that remain fluctuating throughout 2 years of monitoring. Both denies having new sexual partners. So what are the possibilities of why the treatment relapsed for the wife? When her titer is 1 in 512, treated again, and then came down to 1 to 16, then 1 to 8, then discharged from specialist clinic after ruling out neurosyphilis. And when is the patient allowed to conceive again? And whether patient will need lifelong titer monitoring.
Okay, the first question, because Nadia, I somehow, I don't know where to open that chat box, to see the questions. And okay, the first question was that the husband, the title has already come down, but the wife is,
Yes.
it's like fluctuating. But what is the
Yes.
fluctuation? Is it like low
So,
title?
I'm not sure whether if the question if Lynn is there, maybe you can explain whether the title of 1 in 512 is a title that relapsed again, or that's the title that she came first with. So it is stated here the title is 1 in 512, and then treated again, and then it came down to 1 in 16, which is more than fourfold, and then 1 in 8. And then discharged from specialist clinic. Lynn, if you're there, maybe you can clarify what's the title when a patient first came in before being treated for the first time in the first round. Lynn is not there, doctor. Yeah. Hello, Lynn. Are you there, Lynn? Okay. If Lynn is not there, doctor, then maybe we move on to the second question where the questioner asks, when is the patient allowed to conceive again? Like
Okay.
after treatment of the syphilis.
All right, what I saw, Lynn, she has typed out, maybe she doesn't have that microphone. So the initial title 1 in 64, and then after that, after treatment, it went to 512. That is definitely a fourfold increase. Okay, this is where your tough thing comes up, because husband already treated, but the wife's one, right, looks like, there is a reinfection. So really have to counsel them, especially the wife lah. Because if this is the only partner, very unlikely it would have gone fourfold. If there's no re-exposure, it should not increase up fourfold, unless really the injection was never given to the patient, the benzathine penicillin, okay, which should not happen. Okay, that's why I say you must also check whether all the treatment was properly administered for the patient or not. Sometimes they put, so painful, they stop the injection curve, the injection come out curve. All these things you really have to reconsider things that can happen. Okay, you cannot get like a fourfold increase like that. Any fourfold increase is significant, all right, and you have to treat lah, and then you really have to talk to both the wife and also the husband lah. And best thing is, since if they are still sexually active, you still need to monitor the husband's title. Okay, and then the usual thing, once the title come down, say that the person is pregnant that time, every month you got to monitor, make sure you get your fourfold decline. Okay, the thing is that you just have to see the value, make sure you get your fourfold decline. And if it's a fourfold increase, you're going to think about reinfection, have to rule out neurosyphilis if this is a second time it's happening. Okay, whether you need to, how long you want to monitor. Let's just say you never get a fourfold decline, right? You have to continue monitoring. Okay, especially all the zero fast, right? Actually, there is no hard and fast rule what I'm going to do. There is no like a guideline to say, okay, so since I didn't get a fourfold decline, what am I going to do with this patient? Keep on treating? Obviously not. Okay, we only treat if there's a fourfold increase. We must make sure HIV has been excluded, neurosyphilis has been excluded, and if it's still like that at that stable titer, we just monitor. If it's like a low titer, you can monitor every year. If a high titer and you're worried, you have to monitor maybe 6 monthly. The only thing you can do is monitoring, especially after you have determined that adequate treatment is given.
And then, Dr. Latha, is there any specific timeline on whether patient will be allowed to see, or if it has not come down fourfold, right? It has remained that way. So is it safe for patient to conceive? And is there any consensus on that?
Actually, there is, as long as we have already monitored the patient, meaning that we never got a fourfold decline with that high titer, you do need to refer to the specialties, dermatology. Sometimes we also refer to R.E.D. We have to make sure that the neurosyphilis part is really ruled out. Because most of the time when you already gave your IM resulting penicillin, why it's not coming down despite no patient don't have re-exposure, partner all treated, is one of those nagging thought is the neurosyphilis. So if you rule out that one also, then most likely this is the serophas for the patient themselves. That means you cannot get that fourfold decline. So you just have to monitor the titer ni. So this should not stop the patient from getting pregnant for sure. But it's just that you must know what was the baseline. So when the patient gets pregnant, and then when you repeat the RPR, you know that this is the patient's baseline. You're not like, oh, so worried about, oh, I must treat so fast, because you know this is the baseline. You just look for any fourfold increase from there now.
All right. So we have several more questions. We'll take the question from participant Loon Cheong Yu.
Good evening, Dr. Latha. I'm new here. I'm from Penang ID. Very informative talk. I know more about syphilis now. I would like to know, does the RPR titer reflect the disease activity? For example, someone that is untreated, but when come to us, no symptom, but the titer is only 1 in 2. Does the level of RPR reflects the disease activity? And the second part of the question is, at times when we do the screening for our patient, asymptomatic, TPHA positive, but RPR, despite repeated to look for prozone, still negative. Would you treat that as a latent syphilis if the patient deny previous treatment and does not recall any previous symptom before? Thank you.
All right, good questions. So the first one, the RPR titer, if you want to say disease activity, it's not disease activity, but to determine, to tell you, give you a clue whether this is early latent or late latent syphilis. Okay, so usually the one with these low titers, 1, 2, 1, 4, up to 1, 8, 1, 8, 1, 16 is like borderline. We usually would put that into late latent, but of course, that questions will come like, if we have like a fourfold difference within 1 year of the RPR, or patient got re-exposure during that 1 year, then we still treat as early syphilis. It's not to say like disease activity, it's just to classify is this early or late latent syphilis. Okay, so because that is important, because your early syphilis, we only treat with 1 dose Penceramah, and then your late latent syphilis will be treated with 3 doses. Okay. And then remember your RPR 1 in 1, 1 in 2, all these are the frequent serologies that usually false positive. Please confirm TPPA is positive. Okay, then only you say this patient is syphilis. And then there comes a second question where you say RPR or negative, TPPA is positive, RPR is negative. Okay, so this can happen. All right, usually these are the late latent syphilis if they have never been treated. Sometimes our own body also, we can actually fight this infection. But if there's no record of any treatment, please treat the patient. Okay, you need to treat the patient, document down in like any book that they have, or maybe give them a piece of paper. Pregnancy better, they have the pink book. But normal people, we don't carry anything with us to say, hey, I'm a treated syphilis. We're not so proud of that kind of fact. So, but then at least somewhere it is documented that patient is already treated. Okay, if there's no documentation of any treatment, TPPA positive, you must treat the patient.
Thank you, Dada. We have 3 more questions from the chat box. If you still have time, Dr. Latha.
I have. It's okay.
Yeah. So the second question is from Dr. Mary from PK Lembah Pantai. So question is, what is the highest serophas titer that you have seen? And does it depend on the baseline titers prior to treatment? And then can the fourfold reduction happen slowly in early latent or late latent syphilis?
Okay. Titer, I have seen that, 512 times 2, oh, it's so bad. 512 times 2 is 1064. I have seen that kind of titer. I have HIV patients who are like, very good. Their CD4 count very high, but then their serophas is always remaining 1024. 1 in 516. We have that group of patients. These are the group of patients we definitely will have sent them for for LP. This group of patients are mainly the HIV patients. Okay, and their serophas somehow stays at a very, very high titer. So we just have to monitor them because there is no any other like guidelines to say how else you want to manage this patient, because they don't have re-exposure, they don't have like, you know, their partners, whoever is all treated already, neurosyphilis has been ruled out. It's just that the titer is persistently there. Okay, so we will just keep on monitoring for that group of patients. What was the second part of the question, Nadia? Or this one?
Syphilis.
Okay. The fourfold decrease is usually very slow for the late latent syphilis. That's why you see late latent syphilis, we need to monitor up to 24 months to see whether we can get that fourfold. Now, early syphilis, most of the time you can get the fourfold. Only there's this small group of patients where it's always persistent there. So don't know why, but we take it as that's their serophas already. Not many at all. I think at most I have 2 patients only.
But just out of curiosity from my side, so if in these patients, especially this HIV patient with very high titers, right? And then especially since we don't know whether they're high risk behavior or not, so how often do we actually monitor the titer? Is it 6 monthly, 3 monthly?
Initially, I would do 3 monthly, and then it's always been the same. So I slowly like see, okay lah, 6 monthly, you know. Yeah, so we'll go around there. Eventually, they will default lah. They get sick of it also. Kami like, oh, doktor sama je, okay lah. Tak ada apa-apa nak buat, tak ada. You know, so they also get like kind of like, but also sometimes I also lose them to follow up already. I think the one that 2 I ever had, right? I can't remember. I haven't seen them for quite some time also.
Okay, so we'll move on to another question from Dr. Muhammad Faizal from PKD Maran. So this question, it says how to approach inpatient we suspect a false positive RPR. The patient is asymptomatic and no high-risk behavior. Do we need to proceed with other tests to prove the other cause, for example, connective tissue disease, or just enough by symptom screening?
As long as I mean, the causes of false positive is what we put there lah. You know, patients elderly, pregnant lady, patient with connective tissue. But we don't have to actively go and look why is it false positive. Don't have to. Not necessary at all. Important thing, establish, is this syphilis or not? You need to treat or not. You take the RPR. RPR positive. You must confirm with the TPPA and TPHA. If it's negative, it's negative. Full stop. Okay, so that means this is a false positive, whatever the reason can be. Okay, we don't have to go and like screen. Oh, it's just like you know, you see dermatomyositis, you want to screen for all these like underlying malignancy. No, for this false positive, it's not something like, oh, because you saw this, you need to go and screen for other underlying condition. No need at all. Your job is to say whether this is syphilis or not syphilis. If it's TPPA negative, it is not syphilis. Okay.
So the second last question, in a pregnant patient that we decide for treatment with RPR 1 in 8, first episode and never, no proof of ever being treated, we do monthly RPR to reveal the titer fall between 1 to 8 to 1 to 4. So is there any role for retreatment earlier than 6 months if the titer do not fall more than 4-fold to aim adequate treatment 4 weeks before the delivery?
No. As long as your titer don't go fourfold and fourfold higher, you're safe. As long as showing is static or coming down, it's fine, especially this low titer. But once fourfold, you see 1 in 8, suddenly you already see 1 in 32, please treat. Okay, this is already fourfold higher. But as long as they maintain 1 in 8, 1 in 4, 1 in 8, 1 in 4, okay, partner all treated already, okay, then you got no reason to worry.
Okay, we do have additional question, and I'm afraid these 3 additional questions are the last questions that we would be able to take. So a question from Dr. Nur Sabrina from PKDJB. She is asking how much injection need to be given for retreatment if the titer does not reduce or decline to 4-fold after the given time.
Okay, so if there's no fourfold decrease and we've decided this is not serofast, you want to retreat, retreat as a late latent syphilis. You need to give 3 doses.
All over again. Right.
Hmm.
Okay. So
Gejala
another another question from Dr. Nurbaino from PKD Gombak. So she's asking, in the case of a high-risk patient, and then the RPR titer came back 1 to 2 with no known baseline titer and no known duration of exposure. So in that case, do we need to treat the patient as late latent or early latent? Or do we need to send TPHA first before starting treatment in the case of high-risk patient?
If you're in high-risk patient, I mean, of course, if preferably you can have the TPHA, you want to confirm it, that would be it is the ideal one. But if you think your patient is not going to come back, you treat. Always say that if you think your patient is going to default, high risk of defaulting, give at least that 1 dose. Okay. As I mentioned earlier, right, if you're unsure, patient say no re-exposure, everything, I mean, like no contact, in the past 1 year, you don't have any other titer, the titer 1 and 2, this is most likely is a late latent syphilis already. If you're unsure at any point, always treat as late latent syphilis. Give the 3 doses of IM benzathine penicillin.
Okay, Dr. Latha, there's another question from your ex-houseman in Perlis, Dr. Muhammad Faisal Hamdi, who's currently a clinical microbiologist in HTF Perlis.
Hi, Faisal.
He just want to comment that there's certain hospitals that are still using the traditional algorithm for syphilis testing, but there is a problem with late latent syphilis with negative RPR. Clinician might miss the diagnosis if they do not order the TPPA. So do you have any comment for that situation?
That's why, I mean, like when this was introduced, this reverse algorithm, even I myself is not very keen about it. I still, because it's confusing, but already you want to interpret the RPR during the follow-up itself is already sometimes very confusing, So now you make it something so confusing, you want to start with the chemical immunoassay first. Then after if that is positive, then you want to go on to the RPR. If the RPR positive, the thing is settled lah. But it's RPR negative, you cannot stop there. You need to repeat another treponemal test. You must do it. So the person who's following the algorithm must follow it properly. You don't follow setengah jalan. Okay, you must follow it properly. That means if it's positive, your RPR negative, you have to repeat another treponemal test of a different type. That means do a TPPA or a TPHA. So that is what the algorithm says. So you must be very, familiar with it. You must know that is what you're supposed to do.
All right. Okay, so the last question for you, doctor. Number one, participants just want to confirm whether a patient in serofast state can transmit the disease or not. Is it safe for the partner if a patient is in serofast state, even if the titer is high titer? And then another participant is asking the mechanism of RTK syphilis, whether it detects antigen or antibody, and what is the window and incubation period for the result to be positive on RTK.
Okay. Okay, let me answer the second one first. RTK is actually the test. We're talking about RTK or RPR? Because RTK is a rapid test. It's just a kit, rapid HIV, all that. Whenever you have that positive, you must do your RPR. Okay, so let's talk about RPR or VDRL, which is actually a non-treponemal test. So this test is actually testing this cardiolipin, lecithin, cholesterol particle. And this particle, right, is actually released by tissue damage. All right, so that means, when the treponemer is dying or something, this is released, and this is, treponemer is there, this is released, and when you're doing the RPR, you are actually detecting this only. All right, So that is why it can be false positive, because this component, right, can be present in elderly, it can be present in connective tissue disease symptoms. So that is why you need the actual treponemal test to confirm it. And all these tests are actually measuring the antibody. That means our body, when we are exposed to like this treponema pallidum, we will produce the antibody. So we are testing, this test is testing the antibody. So this test contains the antigen. The test kit is the antigen, the antibody is coming from the patient. All right, so that is how the basis of this treponema and non-treponema test also. So this antigen antibody has to what it is, it has to have formed this clumping, and this is the basis where they will detect when they're doing that dilution of this RPR. Okay, so I hope that answers that second part of the question, which I have to ask Nadia. What was the first part of the question again?
So the first question is just a query regarding a patient in serofast state. So some patient can still present with a very high titer, right? Which we have labeled in serofast state. So do we assume that they are non-infective to their partners?
Yes, that means once you already confirm this is serofast, meaning that you have adequately treated, you have monitor, like 24 months already, the titer keep on being the same, or they actually only fluctuate within, twofold. That means one dilution with twofold only. There's nothing more than that. And then especially for high titer, usually we must rule out neurosyphilis, and all this thing is done. We say that this is the serofast for the patient. Very rare, you get. How many of you here ever actually seen that? Because it's actually very rare. And usually if you're like in doubt, you just refer to ID team or even the derm team. Then we will know how to actually monitor and determine.
All right,
Not
so that's the... Yes.
not one. Don't base everything on just one title. We need a series of titles just to, come to that conclusion of this is serofast.
Yeah. So for person in serofast state, despite a very high titer, we just need to repeat the titer, right? But there's no consensus on how many titer repetition before we say that this is a serofast state.
At least that for late latent, the 24 months is like that timing that we need. Okay, and then for early syphilis, it's the 12 months. By then, we must decide whether what it is this treatment adequate, not adequate. If said at that time you want to treat, you will retreat. Then after retreat, if it's persistently the same, then that's when we already say that this is likely to be serofast already. If we don't get our full decline.
This is after ruling out neurosyphilis and
Yes.
all other things.
Yes.
Yeah. Okay. All right.
And
So
yeah.
So that's the last of the question, Dr. Latha. Thank you so much for your time and for your wonderful presentation. I certainly have gained a lot of insight and new information today. On behalf of Unit HIV, STI and Hepatitis C of Jabatan Kesihatan Negeri Johor, I would like to extend our sincere appreciation to you for sharing all your expertise and clinical insight. And I believe today's session has provided a greater clarity to everyone in interpreting rising RPR titers, particularly differentiating from serological variation. And I'm sure that everyone find that this talk has been highly relevant to our daily practice. To all participants, thank you for taking the time to join our session today. As mentioned earlier, today marks the first of many upcoming CME sessions by Unit HIV and STI, and we will announce our CME from time to time. We hope to continue bringing more relevant and beneficial academic discourse in the future. Please do not forget to fill up your attendance form, and the link is posted in the chat box. And thank you, and stay safe and have a pleasant day, everyone. Bye.
Thanks,
Thank you,
everyone.
Dr.
Bye-bye. Bye.
Assalamualaikum.